Good afternoon and welcome to our webinar on breastfeeding. This has been a very interesting topic, and it's been fun for me to have a chance to go out into the literature and pull all of this information together because unfortunately uh, there is not much information in one place regarding breastfeeding by chemically dependent women. The most important thing we want to remember is that we do want women to breastfeed. Breastfeeding improves infant nutrition. There are lower rates of infections and allergies in infants and children who have been breastfed. Breastfeeding promotes attachment between the mother and child, which especially is important when we talk about women with a history of chemical dependence. Breastfeeding gives women a feeling of empowerment and promotes self-esteem. And when it comes down to it, what we know is that just like recovery promotes good parenting promotes recovery. So I find that allowing women to breastfeed can enhance recovery and give the woman a greater feeling of attachment to the infant and a greater feeling for herself of empowerment. However, and this is important, any woman who is using substances, those substances that she ingests will cross into the breast milk fairly rapidly. And that goes to just about anything you can think about. And so we know that if a woman is breastfeeding, abstinence from drugs is important. Now, what we're going to do this afternoon is address each substance individually. We're going to start with nicotine. Now, the data I'm going to include in this that tells you rates of nicotine use come from a recent study we've just completed on 78,111 women. All of these women are pregnant and underwent screening with the 4Ps plus. And what we were able to do was gather data on the prevalence of substance use and the specific substances among these women, both prior to knowledge of pregnancy and then once the woman found out she was pregnant. We do not have information on rates of use after the woman delivers, but we can infer from rates prior to pregnancy, we can infer rates for after completion of pregnancy. So for nicotine, we found that 18% of pregnant women had been smoking tobacco in the month before the woman found out she was pregnant. Once she found out she was pregnant, that rate dropped to 11%. Now, the important thing about nicotine is that it is rapidly and completely absorbed from the mother's respiratory tract into her bloodstream. So the nicotine passes directly across from the lungs through which she's inhaled the nicotine into her bloodstream. And then the process of transferring the nicotine from the bloodstream into the breast milk is by simple diffusion. So what that tells us is that there is direct transfer of nicotine into the breast milk immediately after the woman has smoked a cigarette. Now, breast milk will contain the nicotine for a good while after last smoking. The way we measure the length of time a substance stays in the breast milk is by looking at the half-life. And the half-life is the time it takes for half of the concentration to disappear. For nicotine, it takes a good hour and a half to metabolize nicotine and get it out of the breast milk, and so half of the nicotine. So what that tells us is a good hour and a half after smoking, there are significant levels of nicotine in the breast milk. And we know that the maternal serum and breast milk levels are pretty equal. So if the woman, before 97 minutes is up, smokes another cigarette, what you can see is you're getting constant levels of nicotine, high levels, in the breast milk. In addition, one of the difficulties we find is that there is the danger of spilled ashes on the infant. And we have seen infants come in whose mothers were breastfeeding them and smoking a cigarette while breastfeeding, And the child has first and second degree burns from the mother's ashes dropping on the infant. And then, of course, there's passive inhalation of nicotine and tar. What you have to remember is that infants and children are much more vulnerable to the absorption of nicotine than are adults, because infants and children breathe more air in proportion to body size, and their airways are much more narrow, so that you get much more direct and rapid effects on constriction of the airways in infants and children due to the nicotine. Now, what complicates matters is that secondhand smoke actually is absorbed more rapidly and efficiently than breast milk allows absorption. So nicotine that an infant has inhaled moves even more rapidly into the infant's bloodstream than does nicotine the infant has ingested through breast milk. And when studies have been done to measure serum levels of nicotine in the baby's bloodstream, we do find that there are higher levels of nicotine from the passive smoke than there is from ingesting it through the breast milk. But the big issue is that the effects are cumulative. That is, both nicotine inhaled passively and nicotine inhaled or ingested through the breast milk add up. So that urinary cotinine levels, and cotinine is the metabolite of nicotine, so urinary cotinine levels of infants whose mothers smoke are 10 times higher in the breastfed babies than bottle-fed infants whose mothers smoke. So you can see that's that added effect. Now, what are the effects of nicotine on the breastfed infant? Well, first of all, nicotine flavors the breast milk. And so there is a higher rate of feeding refusals in infants who have whose mothers have smoked cigarettes. We also know that nicotine is an appetite suppressant, which is why it's often so difficult to get women to stop smoking, because it does help control weight gain. An infant whose mother has been smoking and has been breastfed has higher rates of vomiting, diarrhea, restlessness, and increased heart rates than infants whose mothers do not smoke cigarettes. And colic occurs much more frequently in infants if their mothers smoke 5 or more cigarettes per day. So you can see that there are direct effects of the nicotine absorption through the breast milk, complicated by nicotine absorption through the inhalation of passive tobacco smoke, that increases the difficulties the infants have, both in behavior and in feeding patterns. Now, one of the questions that's come up is the question about a nicotine patch use during pregnancy. A usual nicotine patch delivers around 21 milligrams of nicotine per day. When you measure nicotine and cotinine in the breast milk, the same amount from that patch crosses over into the breast milk as if the mother were smoking an average of 17 cigarettes per day. So you can see you do get significant amounts of nicotine in the breast milk if a mother is wearing a nicotine patch. Now, fortunately, if you are able to decrease the nicotine levels in the patch to 14 milligrams a day or even 7 milligrams a day, you do get lower concentrations in the breast milk. So what can we say to the mother who is continuing to smoke during pregnancy? And we all know how difficult it is to get a woman to stop smoking during pregnancy. First of all, try to reduce the number of cigarettes per day and to change to a low nicotine brand. Also, the woman should smoke after breastfeeding rather than just prior to breastfeeding. And if she is going to smoke, to try to wait at least 90 minutes. Remember, that's the half-life of nicotine in the breast milk. So to wait at least 90 minutes after the last cigarette before breastfeeding. Now, the other difficulty we get into, and this is almost a vicious cycle, if a woman smokes a cigarette and then breastfeeds the baby, as we said, the baby's going to get more fussy. But what do most breastfeeding mothers do if their baby is fussy? They breastfeed. And so what you get is building levels of nicotine in the already fussy baby. So as I said, what you're going to try to have to do is avoid breastfeeding for about 90 minutes after smoking the last cigarette and use other calming techniques for the infant. Now, what about environmental tobacco smoke? Although that's not the topic of this webinar, it has direct implications. And so I want to talk about a few of the guidelines that we can use when we're talking to families, and even if the mother's not smoking, if anyone else in the family is smoking. What are some guidelines that have been shown to reduce the exposure to environmental tobacco smoke? So what I want to talk about is what intervention guidelines can we provide to families in which somebody is smoking in order to reduce exposure to environmental tobacco smoke. Number one, family members should smoke only outdoors. And that should be for any visiting family members and friends also. Refrain from smoking close to the child. Avoid smoking in automobiles. We know in a closed automobile, especially during winter when the windows are all rolled up, you get intense levels of airborne contaminants from tobacco smoking. Obviously, try to smoke a fewer numbers of cigarettes each week. Smoke when the child is not present. But be aware, even if you follow all of these guidelines and you're smoking outside, when you come inside, your clothing and your hair still carry the contaminants from the environmental tobacco smoke, which then are passed to the infant or child. So as a general rule of thumb, it's best if you can cover your hair and clothing when you're smoking outside, or even better, completely change your clothing after you smoke. We're now going to move to the discussion of alcohol. And as you can imagine, there are strong feelings on both sides of the coin when it comes to alcohol use while breastfeeding. Now, in our study of the 78,000 women, we found that the rate of alcohol use across the board prior to knowledge of pregnancy was about 25%. Once the women found out they were pregnant, that rate dropped to 9%. Now, that's good news, obviously, but those babies are still being exposed during early pregnancy before the mother knew she was pregnant. Now, again, alcohol rapidly transfers into the breast milk through simple diffusion, and so the maternal serum and breast milk levels are the same. And alcohol does flavor the breast milk and changes the smell. So again, you can get feeding refusal if there is alcohol present in the breast milk at the time the woman is trying to breastfeed. There are a lot of urban myths out there, one of which, and we hear this all the time, drink some beer, it helps produce more and better milk. Well, there are a number of studies of that myth. Now, what we know and what the studies have shown is that one standard drink of alcohol reduces milk volume by about 23%. So contrary to what the urban myth says, you'll produce more and better milk, you in fact produce less milk if you have even one drink of alcohol. Now, 2 drinks of alcohol interferes with oxytocin release. And oxytocin release is necessary for the milk ejection reflex. And so you not only now have less milk, but the ability to push the milk down into the ducts and on into the nipple for the infant is impaired if you've had 2 standard drinks of alcohol. And contrary to what we often hear, have some beer, this will increase the caloric value of the breast milk. This is completely untrue, and there is no change in the caloric value of the breast milk after a woman has ingested alcohol. One of the things we have to remember is that infants detoxify alcohol at about half the rate of adults. until they're at least 3 months of age. And so the alcohol stays in the infant. If he's ingested breast milk that has alcohol in it, the alcohol stays in the infant at higher levels through that first 3 months of life. Now, long-term effects of alcohol drinking during breastfeeding, there's a lot of controversy over this issue, and there's mixed information regarding long-term outcome. What studies have shown is, first of all, one standard drink a day while breastfeeding has been associated with a decrease in psychomotor development, but that's just in some studies, not all studies. Other studies have shown that one standard drink results in the infant sucking harder and faster, but getting less milk and becoming more sedated than in infants whose mothers did not drink any alcohol. So you can see we have some direct and indirect effects that have been found, but at the same time, these effects are not consistent in all studies. So it leaves us as healthcare professionals working with these moms with a mix of signals. And so what we want to do is to be very clear. The advice I give mothers who are breastfeeding is I would prefer them not to drink. However, if they are going to drink alcohol, here's some general guidelines we can give them. It's best not to have any alcohol at all, or to minimize the alcohol as much as possible for at least the first 3 months of life for the infant. If you're going to drink, eat before and while you're drinking. That decreases the amount of alcohol the mother will absorb. Drink plenty of non-alcohol beverages at the same time. And if you are going to drink, and especially, what happens, we'll get a call, a woman will say, it's New Year's Eve. I'm breastfeeding, but I want to go out and, I want to celebrate New Year's Eve. What we'll tell her is to drink plenty of non-alcoholic beverages while she's drinking alcoholic beverages, and to be sure to continue to eat while drinking, and then to pump and discard the breast milk for at least 2 to 3 hours after the last drink. Now, this is pretty onerous, and a lot of women will select not to drink rather than have to pump their milk for 3 hours. But this is really the best safe road. And of course, store alcohol-free breast milk for use after moderate or heavy drinking. So those are some steps you can take. I think that you have to modify these based on your own approach to practice, because all of this is a best use of research that I can find to back up my recommendations, but all of this may not be necessary. And that's why you have to make a clinical decision of how you're going to use this information to advise the woman who's breastfeeding. The next topic is caffeine. Now, there is, again, a lot of very mixed information about caffeine in use in breastfeeding women. We know that the transfer of caffeine into breast milk is more complicated, and so is much more highly variable than it is for alcohol and nicotine. In general, we find that peak levels of caffeine are found in the breast milk about 1 hour after the mother's ingestion of the caffeine. However, less than 1% of the maternal dose of caffeine is transferred into the infant. And so when it comes down to it, 1 or 2 cups of coffee are probably clinically insignificant for the infant. So can a woman drink caffeine and breastfeed? The answer appears to be certainly within moderation. Caffeine is fine. You do have to realize that caffeine can accumulate in the infant, however, because newborn infants can take up to 80 hours to metabolize caffeine. So even with small amounts, you may get a buildup of caffeine in the infant. Now, by 6 months of age, infants are able to metabolize caffeine in about 2.5 hours. And so you can see over that first 6 months of life, the infant becomes much more efficient in metabolizing caffeine, so that the mother can begin to loosen up her caffeine guidelines. Again, 1 to 2 cups of caffeine at once are probably not clinically significant, and over time she can increase the amount of caffeine she takes. However, she still has to be careful. Now, what you do have to remember is that there are some studies that show that 3 or more cups of coffee a day does reduce iron content of breast milk to about 1/3 of the iron content in breast milk for women who do not consume coffee. So the question has been raised if chronic consumption of high levels of coffee can result in iron deficiency anemia in the breastfed infant. Again, there is no proof of that. It is a theoretical question, and bottom line, caffeine consumption within moderate ranges is probably safe for the breastfeeding woman and her infant. Talk about controversy. Now we're going to move to a discussion of marijuana use during breastfeeding. Our studies showed that prior to knowledge of pregnancy, about 9% of women had been smoking marijuana. Once they learned they were pregnant, this rate dropped to about 3%. And marijuana use and breastfeeding, the general guidelines that we talked about with tobacco, pretty much hold true for marijuana. Marijuana is rapidly absorbed from the mother's lungs, from her respiratory tract, into her bloodstream, and the passive exposure to marijuana smoke is pretty much the same as what we talked about for tobacco. Now, marijuana is metabolized in the liver, and the half-life of marijuana in the bloodstream is anywhere from about 2 days up to about almost 60 hours, so 25 to 57 hours. Chronic users, however, because marijuana is stored in the body fat, marijuana, the half-life in chronic users can be up to 4 days. And what studies have shown is that you can find levels of marijuana in the maternal urine for up to 1 month after the mother's last use. So what you see is that with especially chronic users, you can get significant marijuana levels in the breast milk for a fairly long period of time. THC, the active ingredient of marijuana, is highly fat soluble and transfers in moderate amounts into the breast milk. And of course, remember, breast milk is almost all fat. So what happens in chronic heavy users of marijuana, you actually get higher levels of marijuana in the breast milk than in the mother's blood. Animal studies have shown that more marijuana reduces basal prolactin levels and thereby reduces the breast milk supply. This has not been shown in humans, though there is no reason to think that this might not be true for humans also. So now we've established that there is marijuana in the breast milk. What are the effects on the breastfed infant? Short term, there is good evidence that the breastfed infant whose mother has smoked marijuana shows more sedation, more weakness, especially as related to muscle tone, and more impeded feeding patterns. That's short term. The long-term effects are absolutely unknown. And this is where we get in difficulty from a clinical perspective. As clinicians, we don't want women to smoke marijuana when breastfeeding. However, we have no hard evidence for long-term outcome. I think the best thing we can do is point them to the statement from the American Academy of Pediatrics. Marijuana is listed in their recommendations for breastfeeding under the category, quote, drugs for which the effect on nursing infants is unknown but may be of concern, end quote. And that's the best information we can give to moms. We don't know the effects, but obviously because we don't know, our recommendation is when you're breastfeeding, you don't smoke marijuana. We get to one of the newer problems now, which is methamphetamine use while breastfeeding. Very little is known. There are no formal studies of breastfeeding by methamphetamine using women. We do know that significant amounts of methamphetamine are transferred into the breast milk. And two studies have shown that about in methamphetamine using women, anywhere from 18 to 68 milligrams per kilogram per day are transferred into the breast milk. Now, there are several clinical reports of women having used methamphetamine and then breastfed their infants. And the infants have suffered seizures, strokes, heart attacks after feeding. And the clear recommendation is that if a woman is using methamphetamine, breastfeeding is contraindicated. We have had some of those cases ourselves in our clinical work, in which infants have suffered significantly after their mothers have used methamphetamine and then breastfed. And so clearly, methamphetamine use is a contraindication to breastfeeding. The next topic is one that we're having more and more exposure to, and that is the use of heroin and other opiates by pregnant and postpartum women. What we found in our large study was that about 2% of women were using heroin prior to knowledge of pregnancy. And that's pretty much in line with what the national data show from SAMHSA and other federal agencies. Once the women found out they were pregnant, the rate dropped to about 1%. Now, heroin does pass rapidly into the breast milk, but has very poor oral bioavailability when ingested, meaning that heroin is absorbed very poorly through the stomach. So the levels in the infant are going to be relatively low. Short-term studies have shown that the baby whose mother has used heroin and then breastfed, the infant is sedated, has some respiratory depression, there's been vomiting, irritability, and if the woman is a fairly chronic daily user of heroin, has been breastfeeding, and then stops breastfeeding, the baby can go through acute abstinence. So if you have a woman who comes to you, let's say you did not work with her during pregnancy, she comes to you now, she's breastfeeding, is on heroin or other opiates, you don't want her to stop breastfeeding acutely, and you don't want her to stop using her drugs acutely. You would want to move her to methadone or another substitute, opiate substitute, and then maintain her in that way. Long-term effects of heroin exposure via breast milk are completely unknown, and in fact, I don't know of any studies that have looked at that issue. Whenever we talk about heroin, of course, we have to discuss methadone. Methadone has multiple advantages clinically, whereas the half-life of heroin is very short, relatively 2 to 4 hours. The half-life of methadone is up to a couple of days sometimes. It depends on the woman, anywhere from 13 to 55 hours. So what we do with methadone is we give a more stable level of methadone in the breast milk for the breastfeeding woman so that the infant is not being exposed to peak and trough levels of the substance. Now, methadone does peak in the maternal serum about a half hour to 1 hour after oral ingestion by the mother. The dose transferred into the breast milk averages about 3%. 2.8% of the maternal dose can be measured in the breast milk. So you can see it's fairly low. And at most doses, methadone is not going to have any effect. However, there have been some studies that reported short-term sedation, respiratory depression, vomiting, from the baby's exposure to methadone. And if the mother stops breastfeeding acutely, you can get irritability on the part of the infant and the acute abstinence, much the same as we talked about with heroin. So, what is our recommendation for women who are on methadone? We like low-dose methadone maintenance. And so we try to get women down to less than 40 milligrams a day while they're breastfeeding, and have been very successful in that. And we had a previous webinar that talked about methadone dosing during pregnancy. I would refer you back to that webinar for much more specific information about methadone maintenance. So in general, we encourage methadone-maintained women to breastfeed, but we monitor the infant closely, and we don't want methadone-maintained women to acutely stop breastfeeding. As we look at cocaine use by a breastfeeding woman, I want to use a specific study that we published several years ago. This was a case study, and the first case study known in which a breastfed infant had been exposed to cocaine. Now, the mother was 26 years old and lived in a northern, relatively wealthy suburb of Chicago. And from my interview with the mother, once I became involved with her after completion of her pregnancy, from the information I was able to gather, the mother used large amounts of cocaine in the first 2 months of pregnancy. She also was binging alcohol, about a half of a fifth of hard liquor, 2 to 4 times a month through the first trimester, and then cut back to 2 to 3 beers a week through the rest of the pregnancy. So you can see there was a pretty significant exposure to cocaine in early pregnancy and heavy to moderate exposure to alcohol through the pregnancy. The mother delivered uneventfully. Her obstetrician had not gathered any kind of substance use exposure during the pregnancy. The infant was delivered at 38 weeks gestation, was appropriately grown for gestational age, and was perfectly healthy looking at the time of birth. The baby was exclusively breastfed. Now, the mother went home, and 1 week after delivery, took a dab of cocaine, as she described it, and placed it on her gums, and then breastfed the infant to see what would happen. And there were no effects as far as she could see. A week later, so the infant was now 2 weeks old, the mother and father were invited to a party. It was a very nice party with a very nice refreshment table, chips, dips, cocaine. And over a period of 4 hours, the mother estimated she snorted about a half gram of cocaine. Now, the mother and father had the baby at the party with them, so the entire time she was snorting cocaine, she was breastfeeding the infant. She did notice some irritability, but as any good breastfeeding mother knows, if the infant is irritable, you breastfeed some more. So the infant, over this 4-hour period, was getting breastfed fairly constantly. They went home, and about 3 hours after the party was over, so after the last cocaine use, the mother noticed that the infant was really quite irritable, was vomiting and having diarrhea. The parents also noted that the pupils were dilated and the infant seemed unable to focus. They brought the baby into the emergency room, and when the emergency room doctors saw the baby, now they didn't have any of the history I just gave you, but they did call me down to examine the infant in the emergency room. And it was at that point that I was able to obtain the history for the first time of this mother's substance use and breastfeeding. The mother and baby were hospitalized, and over the period of the next few days, the baby did significantly improve. It gave us an opportunity to, however, to track cocaine levels and cocaine metabolite levels in the breast milk and in the infant's urine over the next 3 days. Now, what this slide shows is the concentration of the metabolites of cocaine, and the metabolite is called benzoylecgonine. That is the primary metabolite of cocaine. And we're tracking the concentration of the benzoylecgonine in the breast milk and in the infant urine. So looking at this graph, let's look at the breast milk first, and that's the lower line. And what you can see is, as best we can estimate, 10 hours after the last cocaine use by the mother, the concentration of metabolites, cocaine metabolites in the breast milk was about 400 nanograms per milliliter. By 20 hours, that had been reduced to 200, and you can see that the cocaine persisted in the maternal breast milk up to about 40 hours after the last use. So that's almost 2 days after the last use, you could still detect cocaine and its metabolites in the breast milk. Now, the infant's urine concentrations of cocaine metabolites, and let me mention benzoylecgonine is an active metabolite, so that the concentrations of the metabolite over that period of time pretty well mimicked the concentration in the breast milk. 10 hours after the last exposure of the infant had about 850 nanograms per milliliter of cocaine and benzoylecgonine in his urine. By 20 hours, that had reduced to 500. By 30 hours to about 200. Now, let me mention here the threshold for a positive urine toxicology is 300 nanograms. So if we had seen this baby more than about 24 hours after his last ingestion, it's likely his urine toxicologies would have been negative. So this shows you how you really can't rely too easily on urine toxicologies as a sole source of information for exposures in infants. You will also note that there was cocaine and benzoylecgonine in the infant's urine for up to 50 hours and a little bit beyond 50 hours after last exposure. So what this tells us is that if a woman is using cocaine, she may not breastfeed. And there have been other case reports as a follow-up to this one, and the effects on the breastfed infant in a woman who has ingested significant amounts of cocaine and then breastfed. Infants have had heart attacks, seizures, and strokes following the breastfeeding. And so again, just like methamphetamine, if a woman is using cocaine in any form, she cannot breastfeed. So what does this come down to clinically? What are the recommendations we can make? Now, if you have a woman with a history of substance use or abuse and she wants to breastfeed, here are some general guidelines. Number one, the urine toxicologies on the mother must be negative throughout the third trimester and at the time of delivery. She must be HIV negative. An HIV positive woman should not breastfeed. We know that the virus, the AIDS virus, can cross over into the breast milk and can be passed through the blood, the cracked nipples that all breastfeeding women get. That recommendation is fairly straightforward. The recommendations around women who are hepatitis C positive, there is much more controversy. The American Academy of Pediatrics states that if a woman is hepatitis C positive, she may breastfeed. However, I will tell you in my own clinical practice, women who are hepatitis C positive, I recommend they do not breastfeed, because we know we can measure levels of the hepatitis C virus in the maternal blood, and the baby is ingesting that blood when he breastfeeds because, again, of the mother's cracked nipples. And so clinically, I do not recommend breastfeeding by women who are hepatitis C positive. that is something that you're going to have to decide on a clinical basis for yourself. Methadone use, yes, as I said before, we do encourage breastfeeding by methadone using women, no matter what dose they're on. Again, clinically, we prefer they be less than on 40 milligrams per day. And finally, the mother has to be monitored and have ongoing negative urine toxicologies. What are the contraindications to breastfeeding? If a woman comes to you, had no prenatal care, and has a history of substance use, I would recommend you not allow her to breastfeed. If there's evidence that she used or misused any substances in the 30 days prior to delivery, would be a contraindication. And if the woman does have a clear history of substance abuse and misuse, but refuses substance abuse treatment, she should not be allowed to breastfeed. In addition, as the healthcare provider, if she does not allow you to communicate with her substance abuse counselor, that for our program is a contraindication to allowing breastfeeding. If the mother's or the urine's toxicology is positive at the time of delivery, or if there is any postpartum relapse at any level for the mother's urines, then she should not be allowed to breastfeed. And then finally, if the mother is HIV positive. This list are the clear contraindications to breastfeeding that we use. Now, there are some special considerations. First of all, with methadone. I recommended that less than 40 milligrams is best, but yes, any dose of methadone use, the mother should be allowed to breastfeed. However, it is best if she's going to stop breastfeeding that she taper down the breastfeeding so that the baby is getting essentially a tapering off of the methadone. That will avoid acute abstinence on the part of the infant. And any woman who is breastfeeding and on methadone maintenance needs to have significant medical supervision for both her and for her baby. The second special consideration is hepatitis C. As I said before, the American Academy of Pediatrics states that women who are hepatitis C positive should be allowed to breastfeed. Clinically, I am concerned about that, and I do not follow that, but recommend that women who are hepatitis C positive do not breastfeed. Alcohol use, some reasonable alcohol use can be allowed, but again, following the guidelines I gave you previously, I think we need to encourage following those guidelines by the pregnant women. And finally, you'll notice that I very adroitly have avoided talking about psychotropic medications and breastfeeding. That needs to be considered on an individual basis. The problem is there is no clear research that can guide us clinically. And so if you have a woman who is on a psychotropic medication, let's just take an example, Prozac, you need to get individual consultation and make that decision as to what is in the best interest of the mother and the infant. Yes, we want women to breastfeed. No, we do not want bad complications, either short-term or long-term. And with the lack of research information, I think the psychotropic medications and each clinical case have to be addressed individually. Now, I've thrown a lot of information at you today, and I think the best thing we can do, and what I have tried to do here, is take all of the research and compile it into some reasonable guidelines. Because granted, quite a bit of this is still controversial. I had given you the research-based information and then translated that into the research-based clinical guidelines that we use in our own practice. If you need anything further, of course, you can contact us through ntiupstream.com. We're looking forward to working with all of you in our future webinars and hope this information has been helpful to you today. Thank you.